So welcome everyone to the first collaborative trainee research presentations. This is the first trainee presentation day that focuses on clinical research. And because of that, it's really excited to welcome you all here today. So my name is Dr. Elizabeth Rideout, and I'm an associate professor at UBC. And I'm speaking to you today as the lead of the UBC lead of the Women's Health Research Cluster. And specifically, the work in my lab focuses on sex differences in metabolism and metabolic disease using just fundamental models such as fruit flies and mice. So before I give further introductions and event details, I'd really like to take a moment to acknowledge that all of us live, work, and play and participate in community on the unceded, unceded, ceded, and traditional territories of the 203 First Nations, along with 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. At the Women's Health Cluster and elsewhere, we acknowledge the importance of the Truth and Reconciliation Commission of Canada's Call to Action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of WHRC's work and our partners' work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. So today, as many of you are, I'm joining you from Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. So now that we've taken a moment to reflect on this land and our role or our sort of relationship to this land, I'd like to introduce the Trainee Research Presentation Series as a platform for emerging researchers to showcase their work on women's health or sex differences and to sharpen their skills in knowledge translation and public speaking. By spotlighting clinical research today, we're not only fostering the growth of our trainees, but also creating a wonderful environment where new clinical applications and practices can be developed and thrive. When I think about what this event means and why it's significant, what comes to mind is that, the word that comes to mind is collaboration. So within the Women's Health Research Cluster, collaboration really lies at the heart of our mission. So by joining forces with the Women's Health Research Initiative and the Gynecological Cancer Initiative, we're able to create a safe space for trainees at all of our organizations to learn from and connect with one another. In doing so, we hope that we're empowering them to address critical gaps in our knowledge and drive transformative research in women's health. This collaborative effort demonstrates our commitment to working across boundaries and disciplines to achieve our goal of advancing women's health globally. Beyond collaboration, the WHRC's partnership with the Women's Health Research Initiative and the Gynecological Cancer Initiative is strategic. By aligning our efforts, we are maximizing our reach and influence within the women's health research community. Essentially, we hope that this strategic partnership will allow us to leverage each other's networks, expertise, and platforms to elevate the conversation around women's health and drive meaningful change. Together, I think we are stronger, more resilient, and better equipped to tackle the complex challenges facing women's health today and in the future. So this event really represents an opportunity to celebrate the achievements and accomplishments of our trainees, strengthen our collaborative bonds, and to reaffirm our collective commitment to advancing women's health research for the benefit of everyone. So I really just wanted to say a big thank you to the Gynecological Cancer Initiative, the Women's Health Research Initiative for collaborating with us, to all of the staff who made this event possible, and to all of you who are celebrating and supporting the work of trainees. So I just wanted to start off the event by introducing the next speaker and welcoming Dr. David Huntsman from the Gynecological Cancer Initiative to share a few words.
Thank you, Dr. Rideout. It's a great pleasure to be here today. Over 20 years ago, Dr. Diane Miller, who is an amazing leader in our community, basically declared publicly she was just sick of seeing women die of ovarian cancer and felt that if people worked together, they could do something about it. And so based on that, we formed OVCare. And We were focused really initially entirely on ovarian cancer, and working as a team, we made some progress. We showed that ovarian cancer isn't one disease, it's several diseases. We found the key sort of molecular features in several types of ovarian cancer, and also started studying where these cancers came from, which led to both a internationally recognized and used prevention program called opportunistic salpingectomy, which Dr. Miller came up with that idea. And also the acknowledgement that you really can't study ovarian cancer without considering what else is going on in the uterus and fallopian tubes. And so we realized overcare really couldn't work. So we did something which is a very BC thing. We just increased in size. We merged with research work going on at this site and also at the BC CDC, and formed the Gynecological Cancer Research Initiative. So we agreed on a mission to work together to use research to decrease the incidence, death, and suffering from gynecologic cancers by 50%. And I find this to be an absolutely motivating mission. And it's no longer business as usual. We have to work together as a team. We have to think about all gynecologic cancers. We have to think about prevention through diagnosis, treatment, and survivorship. And we also, if we're going to achieve our goals, we can't leave anyone behind. We have to work across our whole community. And this has led to many new partnerships and a new emphasis on population-based knowledge transfer, and the need to work with groups like the Women's Health Research Cluster and the Women's Health Research Institute to achieve these goals. So we're really happy to be part of this. So for me as a laboratory researcher and a pathologist, thinking about population health is certainly outside of my comfort zone, but that's where all the good stuff happens. So if you're feeling too comfortable in your work, you're probably not talking with the right people. And for trainees, I would really recommend moving outside the things you do and to learn from your colleagues who are doing things which you find challenging. So this is a wonderful opportunity for us to celebrate our trainees. We wouldn't get anything done without you. And we really hope that working with us represents a wonderful way to bring your careers forward and to help them develop. We do have at the GCI a research day on June the 17th. Anyone who's interested is welcome to attend. We also have monthly rounds, which Almira organizes. Everyone's welcome to attend those as well. We do provide lunch. And thank you for including us in this amazing day. And I look forward to hearing about your research.
So next we have a few remarks from Dr. Paul Young from the WHRI.
By our strategic framework for trainees and mentorship. We are grateful for this opportunity to collaborate with 2 other women's health organizations to amplify trainee research. Thank you to Catherine Moore and Liz Rideout for bringing us all together. I'm sorry not to be with you today due to another engagement, but I feel passionately about the event theme of clinical and applied research. Thank you to the Women's Health Research Cluster and to the Gynecological Cancer Initiative and all those who are involved in this event. I hope you have a great day together.
Great. So is everyone able to hear me again?
Yes.
So thank you so much for to Doctors Huntsman and Young for your remarks. So now I'd like to welcome Alex Lukey and Amy Thatchell to join us in moderating today's talks and point out the cluster's Director of Operations, Catherine Moore, who will be closing the event later on. Alex has been a WHRC trainee co-lead for 5 years now and has moderated almost all of our trainee research presentations, which has been an absolutely huge task, on top of completing a PhD in population and public health. Amy is one of the cluster's event and communication assistants and took the lead in coordinating today's event. and recently completed her master's in experimental medicine. So take it away. I look forward to seeing the rest of today's talks.
Thank you so much, Dr. Rideout. All right, so Lorena is an undergraduate student who completed an 8-month co-op term at the Huntsman Lab at BC Cancer Research Institute and is currently pursuing a directed studies project at the lab as well. She works under the supervision of Dr. Faria Kabir, and their research is on high-grade serous carcinoma and exploring the pressures of non-cytotoxic and cytotoxic therapies on this type of carcinoma. All right, you're all good? Yeah, you can leave that on.
Okay. Okay. Good afternoon, everyone. I'm happy to be here today. So today I'll be presenting our project on the evolution of high-grade serous ovarian cancer under the pressure of non-cytotoxic and cytotoxic treatment. So just starting off with some background, high-grade serous ovarian cancer accounts for around 75% of epithelial ovarian cancers, making it the most common type of ovarian cancer. And as well, the first line of therapy for this type of carcinoma is chemotherapy. However, more than around 80% of women who suffer from stage 3 to 4 of this cancer unfortunately relapse following frontline disease and actually develop a resistance to chemotherapy. As well, the outcome of those receiving neoadjuvant chemotherapy is poor, with a median progression-free survival of around 13.8 months. And as well, this type of cancer is highly aneuploid and presents as a multi-site peritoneal disease, which raises a question as to how the clonal composition is shaped by treatment. And more recent advances have actually been in PARP inhibitor therapies, with the greatest benefit seen in olaparib maintenance therapy, with a median progression-free survival of around 56 months. And as well, non-cytotoxic targeted therapies have shown promising results as upfront chemotherapy sparing treatments. So onto our aims for this project. The first is to investigate the response of non-cytotoxic therapies on BRCA wild type and BRCA1 deficient cells with in vivo models, as well as to study how selection operates on clones through cytotoxic and non-cytotoxic therapies and changes tumor heterogeneity and genotypes. As well, this one we're currently really working on, but to explore if targeted therapies should be given before or after chemotherapy. So our first method was using patient-derived xenograft, also known as PDX models. So using cell lines BRCA wild type and BRCA1 deficient to represent deficient or proficient homologous recombination. These were injected intraperitoneally to mice to develop these models. And as well, acidic fluid and mouse organs were used for evidence of seeding and identification of biomarkers. And as well, we've taken 10 treatment-naive PDXs, and these were developed in immunodeficient mice and were injected with either cisplatin or olaparib. This kind of just shows our progress of our PDX model so far. So each circle represents a tumor-bearing mouse, and then the numbers at the bottom kind of shows the generations of our serial transplantations that we were working on. And then our second method is using syngeneic mouse models. So essentially we take transfected luciferase expression to monitor tumor response of either high dose intensity or low dose intensity of olaparib, bevacizumab, and atezolizumab drug combinations. And here in this photo, you can kind of see how that works. So you see the transplantation of the viral cell lines as well as the control, and the bioluminescence allows us to kind of see the tumor growth past transplantation. So some of our results, firstly, we found that the triplet drug combination has shown better response in vivo despite the BRCA status. So the two diagrams on the right, it shows the BRCA wild type and the BRCA1 deficient, and we can see how the triplet drug combination has improved regardless of which BRCA status it was. As well, using single cell genome analysis of olaparib treated, we were able to see the dynamic clones over time. So that's a heat map on the left, and then on the right, this shows the analysis of olaparib treated and untreated PDX, and we can see the clonal prevalence of each sample over time. And then finally, shallow whole genome sequencing of a patient's tumor into 2 PDX passages showed a similar features of human tumors. So you can see in the histology the similarities between the patient and the mouse tumors. So our future directions is to just continue investigating different targeted drug combinations and their scheduling in various systems, as well as to continue serial PDX transplantation and treatment for 5 passages to decode the tumors at a single cell DNA and RNA level. And again, we're currently working on that third aim to explore whether targeted therapies should be given before or after chemotherapy. So yeah, that concludes my presentation. I wanted to thank Dr. Yvette True and Dr. David Huntsman, as well as my supervisor, Farhia Kabir, and as well as the rest of my Huntsman lab members.
All right, thanks, Lorena. Next up, we have Pamela Bai. So I'll have you come up to the stage. So Pamela is a fourth-year undergraduate student at UBC in the Department of Pharmacology. She's a strong interest in women's health and is currently working part-time in the Uterine Health Talhouk Lab, primarily on the detector study. Her current role is to develop questionnaires, protocols, and preparatory documents that will be utilized in the clinical trial to improve endometrial cancer risk prediction and identify opportunities for early intervention. All right, I think it should be loaded. All right, perfect.
Thank you so much for the warm introduction. So I'm Pamela, and thank you everyone for coming today. And the title of my presentation is the Evaluation of Variables Associated with Endometrial Cancer Risk and Pathogenesis, a questionnaire-based approach. So endometrial cancer is the most prevalent gynecologic cancer in the developed world and is part of the reason of why we're all here today. And currently, with the standard of care, abnormal uterine bleeding is the primary symptom that prompts detection of endometrial cancer through a biopsy. However, biopsies are very nonspecific and they can be painful and often delayed to scheduling. And there's no other indicator to detect endometrial cancer. And that is really one of the main goals of our lab, to find these alternative methods that can improve patient outcomes. So with the detector study, this is a very large clinical study that we're just getting started. The overall objective is to investigate less invasive and easily accessible self-sampling methods as an addition or replacement of endometrial biopsies to detect endometrial cancer. Questionnaires will play a key role in this clinical study to identify various factors associated with the persistent somatic mutations in the uterus in combination with biological samples and medical information and overall patient information to improve an algorithm EC risk prediction model. We have two main phases in this study. With the first one, we're hoping to recruit about 1,000 participants who are presenting to a gynecologist with abnormal uterine bleeding. And the questionnaires administered in this phase will really want to gather more information about their medical history and the symptoms related to their abnormal bleeding. With phase 2, we'll use a smaller subset of participants, and they'll be administered both longer and shorter weekly questionnaires to monitor their different lifestyle factors and health-related information over a 6-month longitudinal period. And again, these topics are very broad, and I'll elaborate a bit more on that. So with this study, a large part of my role was to develop the questionnaires, and it included a lot of literature searches on various platforms to find these pre-existing validated questionnaires that are proven to gather the information that they're supposed to gather. With phase 1, we found many menopausal staging, menstruation, and medical history questionnaires, including but not limited to the Menopausal Health Questionnaire, the MVJ scale, as well as various STRAW criteria. With phase 2, we had a super broad range of topics recommended by our study gynecologist, as well as some patient partners, including mental health, endocrine disruptors, and sleep quality. And for those topics, we use the GHQ-12, the Women's Health Questionnaire, as well as the PSQI, which is a sleep quality index. With multiple rounds of revision and input from different stakeholders, including our study gynecologists, as well as, very importantly, our patient partners. There are a few women who are part of our study and offer a lot of insight throughout the entire process. They've given more information about just patient feasibility, especially with the second phase, which is over 6 months, and making sure that we're using short, concise questionnaires to maintain participant retention through the whole thing. And also with just individual experiences they've had with endometrial cancer that weren't captured on these broad general questionnaires. And we wanted to make sure to be as concise as possible. We're just about wrapped up making the questionnaires and moving on to further development of our study. Just getting down some of the nitty-gritty details, and we're very hopeful and optimistic to start recruiting in the next month or so and to continue for around 2 to 3 years in this study. That wraps up my presentation. I want to thank my detector team as well as our patient partners and everyone for listening to my presentation today. Thank you.
Thanks, Pamela. Next, we'll have Jordan Lewis. Come up, please. So Jordan Lewis is a fourth-year obstetrics and gynecology resident at the University of British Columbia. She obtained her medical degree from the University of Toronto prior to returning to her home of Vancouver, BC. She continues to apply her background in quality improvement and medical innovation on active research projects, including a local QI initiative on cervical cancer risk reduction with adjuvant HPV vaccination at the time of colposcopy. She looks forward to learn and collaborate with multidisciplinary members of the GCI, WHRI, and WHRC in our endeavors to improve women's health. Welcome, Jordan.
Perfect.
All right.
Okay, thank you for the welcome. So as mentioned today, I'm going to be looking at things through a different lens, away from maybe more traditional research and with more of a quality improvement lens. So I'm going to be talking about at the VGH Colposcopy Clinic, a quality improvement initiative where we're aiming to increase HPV vaccination at time of LEAP. I have no conflicts or disclosures to declare. So we know that HPV is the primary contributor to over 90% of cervical cancer, and this is the rationale for universal vaccination being recommended for cervical cancer primary prevention. So this is what's motivated a lot of funded school-based immunization programs. But despite this, in BC, it's been quoted that up to 1/3 of eligible students have not been fully immunized. And when you can add that to those who missed out on this program, it leaves a large unimmunized patient population. So this speaks to the importance of secondary prevention, which is aiming to mitigate the impact of a pre-existing disease. And this is the role for cervical cancer screening. But vaccination may also have a role for secondary prevention as well, as there's been growing evidence that actually vaccinating around the time of LEAP reduces the risk of recurrence of high-grade cervical dysplasia. This was summarized by this meta-analysis published in 2021, which quoted the overall risk reduction of about 65%. So overall, it's not too late to vaccinate. And this is what motivated our study through the VGH Colposcopy Center. So we know that this is a major referral center in BC, where we perform up to 20 LEAPs per week. And a baseline survey coming through showed that there was about 50% of unvaccinated patients, and up to 3/4 of those patients were willing to receive the vaccine. So this showed demonstrable room for improvement with excellent patient buy-in. So our objective was to increase the total vaccination rate amongst eligible patients by 15% through both patient education and awareness, and by offering them Gardasil 9 prescription at the time of their LEAP. So this was an interrupted time series study with QI methodology, where eligible patients first underwent a nurse-led patient questionnaire, which surveyed demographics and vaccination status. And amongst those who were unvaccinated, they were counseled as to why we recommend the vaccine and provided a prescription. We then saw these patients later at their 6-month post-LEAP follow-up visit, and the aim of this component of our study was to confirm whether the vaccine series was started, and if not, explore barriers or rationales to why, to help motivate further initiatives, and also offer them another prescription. So our primary outcomes were both the total vaccination rate as well as the proportion of eligible patients who started their vaccine series. Balancing measures included out-of-pocket cost and vaccine adverse events. And a secondary outcome was also to survey barriers to HPV vaccination amongst the unvaccinated cohort. So we concluded patient recruitment in June, and this showed that about 58% coming through were actually unvaccinated. And interestingly, the most commonly reported reason as to why was actually lack of provider recommendation. 48% were definitely interested in vaccination, some declined, and some were undecided. And a total of at least 55 prescriptions were confirmed as given. We tracked the weekly proportion of patients that left their first LEAP visit with a prescription. And you can see that the beginning did quite well, which makes sense. But at around week 8, there was clearly some demonstrable room for improvement. And this allowed us to apply the QI process changes, where we had a team meeting and tried to evaluate situations where prescriptions weren't being offered, and then also answer some frequently asked questions. And you can see actually that the proportion of prescriptions that were given out after this intervention jumped from 70% to 87%. So we've seen all but 6 patients in follow-up so far, half of whom have actually started their vaccine series and half still remain unvaccinated. So when you contextualize this with the baseline vaccination rate to 42%, this has now increased our total vaccination rate to 68.5%. As you may recall, our objective was to increase vaccination rates by 15%, and this is already a 26% absolute increase. So among observing adverse reactions, most of our patients had none. Some had a few local side effects, and approximately half of patients, unfortunately, did have to either pay fully or partially out of pocket for the vaccine, which on average is about $200 per dose. Amongst those who remain unvaccinated, the most commonly reported reason was cost, followed then by lack of time and having forgotten or lost a prescription. And then at this follow-up visit, at least 34% of these patients still remained interested in the vaccine, and we confirmed that at least another 15 prescriptions were given again. So takeaways from this, I hope that you were able to learn about the importance of vaccination in this high-risk group, and that you're better able to identify and counsel those who may benefit from an improved understanding of vaccination in this context. And I think that this study really does show how opportunistic counseling at a time when patients are particularly health motivated can really make a big difference. And lastly, I hope that this helps inform, this demonstrates really the translatability and simplicity of QI. And ultimately, I think we need more projects similar to this to basically advocate for this to become more financially accessible. So thank you very much for listening. Thank you to Dr. Proctor and Dr. Justin McGinnis, as well as those involved with the BGH Colposcopy Clinic for making this possible.
Thank you, Dr. Lewis. So I'll actually invite our speakers, if they're comfortable, to grab the seats at the front of the room there. So we're going to start our question period here, and I'm actually just going to turn on their mic at the front. Yeah, do you mind just speaking kind of loudly? So then that should pick you up. Okay, thank you so much. And then just a reminder that we do have one online speaker as well. So is that everybody? 3? Yeah. Okay, perfect. Sounds great. So we'll start off, anybody in the room. I'm not seeing any Slido questions just yet, but would anyone in the room like to start us off? And you can just go ahead and start speaking or put your hand up, whatever you feel most comfortable with. Nobody? I'm just going to start a timer for myself so we don't go 2 over. I can pick up on one thing Dr. Lewis was just speaking about. So you mentioned about cost. I was just wondering if you could talk a little bit more about your thoughts about roles of government, or, how do we get past that barrier for folks? Because I'm imagining most people coming to this clinic are well past the age where this would be covered for them.
Yeah, for sure. So it's definitely kind of, as I mentioned, like you really need to demonstrate how simple and applicable something like this can be, and how effective it can be to increase vaccines and that sort of uptake in patient buy-in. And it's been demonstrated in other provinces that actually, I think it's in, if I'm not mistaken, Winnipeg has already started to fund vaccines for this patient population specifically. So there's definitely been a clear demonstration that it's possible. And so I think that would be then looking forward in future directions after this, is we would then be taking part of the information that we've gathered from this and bring it forward to the government to try and advocate for improved funding. And the other thing that we're looking at too is that the WHO has come out with a recommendation that maybe 2 doses would be sufficient for this context as well. So that does decrease the cost by 1/3. So that's something that we can also keep in mind as well.
It's a great point. So I'll just check, can folks online hear okay? Yeah, okay, perfect. Sounds great. That's really interesting to hear that in other provinces. So that's specifically people coming in for colposcopy.
Yeah, at time of colposcopy, they actually just get vaccinated at the time because it's covered.
Great, very interesting. Anyone in the room? Yeah.
For the high-grade serous project, so the idea is that you'll eventually get to the point where you'll examine whether or not giving PARP inhibitor prior to chemotherapy may make chemotherapy more effective. Can you talk a little bit about what mechanism might be behind that?
In terms of what would make PARP inhibitors better as opposed to chemotherapies?
Yeah, like PARP inhibitor before chemotherapy. Is the hypothesis that that might be more effective?
That's kind of the idea right now that we're like essentially trying to find. Also, as I said at the beginning of my presentation, PARP inhibitors have a higher median progression-free survival, which is good. And also cisplatin, the drug that we're working with, the chemotherapy, is very cytotoxic. So we're kind of trying to move and see if we can implement other targeted therapies before that. So that's kind of the idea right now.
Moving away from cisplatin entirely, possibly?
I don't know if entirely would be feasible, because obviously, chemotherapy has helped us a lot, but I think more so just giving alternatives for different types of issues. I think that's essentially what we're trying to figure out.
Great, thank you.
For your surveys, how are you going to reach across our population, and particularly ethnic groups or geographically dispersed groups who may be hard to reach through, let's say, the clinics of the Vancouver General Hospital?
Yeah, definitely. So I didn't have too much time to get into it, but with our patient recruitment, we're going to be doing it through gynecologists. So starting with around 15 to 20 all around the province in rural and urban areas. And then they'll be the ones that help us to identify eligible participants based on our inclusion and exclusion criteria. And again, just like emphasizing the idea of diversity and inclusion. But it does like depend on who's referred to those clinics and who the gynecologists identify as eligible.
And do you have to, is it just a matter of translation, or do you have to change the surveys to make them culturally sensitive in any ways?
We have some previous surveys that were used in a related clinical study, and we've been adapting them. Those ones we have been trying to make as inclusive as possible. We have a few demographic questions that are optional just to make sure that we're reaching a broad representative population. But I do think equity and inclusivity is like a very big problem that we're trying to address as much as we can. We're just doing our best and really trying to do everything we can to address it.
Thanks.
Thank you.
Any other folks in the room or online? I suppose we'd originally thought Slido only for online, but if you is it okay now? Okay, sorry about that. But if you have a question online, I think we have a small enough group that if you want to unmute yourself, then that's okay as well. Dr. Idriak, I also have a question for you. I was wondering if you could speak a little bit more. One of your slides was talking about regarding education for women's heart health, like time is a barrier. So feeling that there's not enough time in the medical education programs. I was wondering if you could expand on some ways you think that we could reduce that barrier.
Yeah, of course. So yeah, so for our survey result, they say like they want to have, they see value in including content about cardiovascular health for women, but the lack of curricular time, because as most of you know, like medical school has a complex project and already structured. So and this is our the second part of our survey. So one part of our survey, we contact the programs that show interest to have a content in cardiovascular health for women, and we try to mitigate with them how we can easily incorporate in their curriculum, and discussion being open between different programs. And hopefully with the educational module that we already have, they can save time on constructing the curriculum by taking already content to implement in their curriculum. So there's work in progress regarding this, but I think we know the problem now is the time. So if we can help the university and programs with having ready to use material and the expertise who can actually even teach it, I think they will give more visibility for them to include in their curriculum.
Great, thank you. All right, if any other last questions in the room? Yeah.
I noticed that with the colposcopy, people mention time as a barrier, but surely it's less time consuming to get vaccinated than to come back to colposcopy again, right? Which is what these people are at risk of. I wonder if there's a way to sort of frame that.
Yeah, and I think too, depending on how far we can get in our advocacy efforts to try and even just bring vaccines to clinic, that already immediately addresses that. Because I think the issue is that a lot of these people, they're fairly young, they're busy with work, they often have families and children, and so it's really just a matter of actually getting out and going to the pharmacy and getting the dose that I think they struggle with. So we could already get rid of that situation if we could offer that vaccine in clinic. But I do agree. I think that there's a lot, we could put a lot of effort into sort of teaching and providing patients with the resources to recognize that if this prevents you from ever having to come back to this, it's worth the time.
Oh, just have one at the back and then we'll go to David. Yeah.
I didn't research the lot, but for now I read only one population level epidemiological studies that actually looked at the efficacy of the HPV vaccine to prevent cancer, and it was Sweden cohort, population level cohort. And I think the research said that those vaccinated in age 12 will had better outcomes for preventing the cancer. Also, I think the age that the girls are now is like beginning of the age where the cervical cancer can develop. So, do you know additional studies that will additional studies on population levels that show? Because also you said that those the ladies that come to your clinics, they're like much older in the age. So basically, the Sweden study showed that even between 12 and 14 year difference, there was difference in the outcomes. So if those women get the vaccine really late, how it affects the prevention and efficacy of the vaccine?
I can't. I'm sorry.
Sorry, I was just going to repeat the question just really briefly. Just I don't know if folks online heard, but it was just related to around the age of vaccination and how that impacts cervical cancer prevention outcomes. If I'm understanding the question correctly, yeah.
So ideally, vaccinating individuals prior to the onset of sexual exposure or potential exposure to HPV is the most effective way. I can't quote you a specific study that's looked at because there has been lots of different research in this, but I think there's a myth out there that getting the vaccine later, it's not worth it, or that it's not going to make much of a difference. And so part of our goal with this project is to really emphasize that that's not true, because not only does the vaccine potentially provide cross coverage against other strains to which that person has not been exposed to HPV, but we also a suspected theory of how this might work about vaccinating at time of leak and why that helps prevent recurrence is that it sort of restores this sort of HPV naive microenvironment and then actually vaccinates them against the high risk HPV. And that's been suspected because often when they do recur, it's those high risk strains that are persistent. And so if you're able to actually immunize that patient against those persistent causes that are more likely to contribute to cancer, it's still very valuable to have. I just think that it's very important to always recommend vaccination, even regardless of age. I think here we recommend up to 45, but we're still vaccinating beyond 45. That's just sort of what the FDA has put at their limit.
Great. David, do you have a question? Yeah.
So until recently, the entry point for colposcopy clinics was pap smears, which is a screening test, which actually biased against the women who needed the screening test the most. Mm-hmm. And so do you believe that the development and we would hope the uptake of self-testing will change the value of the program which you're researching?
In terms of changing
the benefits would the benefits of vaccination be greater in a colposcopy clinic, which was the majority of patients came from self-testing programs as opposed to the old referral patterns? I
mean, I do actually think so, because you're considering those patients who maybe, as you sort of alluded to, may have had a harder time accessing care. And so they may not have had as many opportunities to have that conversation with a healthcare provider where a vaccine would be recommended. So I certainly think that you might be capturing more of those individuals, because if they self-swab and they've got the kit in the mail and then they come back with high-risk HPV and they're connected to colposcopy, I would suspect it's more likely that they would be coming in potentially unvaccinated, especially if they sort of missed out on that school-based program. So, but I do, just to kind of speak to, I do believe in the value of the HPV self-testing in terms of allowing this to be a really good way to try and catch things before they actually get to a point of cervical dysplasia. So, yeah.
Great.
I don't know if that answers your question.
Yeah, I think we'll have to cut it off there, but it's been great discussion. Thanks everyone for your questions. I'm going to hand over to my colleague Amy to moderate the second half of the session. That's just up there.
Thank you, Alex, and hi everyone. So up next we have Behi Albiswaini. Behi is a research fellow pursuing his PhD under the supervision of Dr. Mohammed Bidawi, with a medical degree from Egypt in 2014 and a master's in OBGYN in 2018. He specializes in endometriosis and recurrent pregnancy loss. His work aims to blend clinical experience and research to advance our understanding in women's reproductive health.
Thank you. Hi, I am Bahi, and today I'll be presenting predictors of medical treatment failure in patients with endometriosis-associated chronic pelvic pain. Starting with a general background, endometriosis accounts for 5 to 20% of women hospitalized for pelvic pain. Hormonal therapy is a cornerstone in the treatment of painful endometriosis. However, no ideal hormonal treatment exists. Therefore, understanding the predictors of failed hormonal therapy is necessary to improve patient outcomes. Neuromodulatory drugs can be used for central nervous system modulation in patients with endometriosis-associated pain, especially when anxiety and depressive symptoms are present. So our objectives were to study the factors which may be associated with hormonal therapy ineffectiveness in patients with endometriosis-associated chronic pelvic pain, and to assess the proportion of patients who use adjuvant neuromodulators for their pain. Regarding our methods, this is a retrospective analysis of individuals with endometriosis and chronic pelvic pain seen at our tertiary center between 2013 and 2017. At baseline, patients were asked if they have ever used hormonal treatments for their pain and if they found these drugs helpful or not. They were also asked if they have ever used adjuvant neuromodulators for their pain. And these are the hormonal treatments and neuromodulators that the patients used. The following variables were studied as predictors of hormonal therapy ineffectiveness: severity of chronic pelvic pain, severity of depression using BHQ-9 scores, severity of anxiety using JAT7 questionnaire scores, and finally, disease burden of endometriosis, which includes evaluation of cul-de-sac obliteration and endometriosis stage. Regarding our results, 1,011 patients were included in the analysis. The mean age at the initial visit to our center was 34 years old, and the mean pain duration before the initial visit to the center was 15 years. As for the ethnicity breakdown, 67% of our patients were Caucasian. Cyclic CHC was the most frequently used hormonal treatment, and 44% of its users found it to be ineffective. On the other hand, NETA was the least commonly used hormonal treatment. Patients who experienced hormonal therapy ineffectiveness had higher chronic pelvic pain scores, except for those who used levonorgestrel intrauterine system. Cyclic and continuous CHC ineffectiveness was related to higher depression scores. Continuous CHC ineffectiveness was associated with higher anxiety scores. Cyclic CHC, dienogest, and GnRH agonist ineffectiveness were more likely to happen with less cul-de-sac obliteration. Patients with stage 3 and 4 endometriosis were less likely to develop dienogest ineffectiveness. And finally, patients who find hormonal therapy ineffective were more likely to use adjuvant neuromodulators, except for those who used NETA. So to conclude, endometriosis-associated chronic pelvic pain is a complex clinical problem with a high likelihood of failed hormonal therapy. Patients with higher CPP, BHQ-9, and JAT7 scores found hormonal therapies to be ineffective and had neuromodulators prescribed more frequently. Patients with high disease burden of endometriosis demonstrated a more favorable response to hormonal therapy, which underscores that the effectiveness of hormonal therapy is not only determined by the disease burden, but may also involve multiple factors. Finally, I'd like to acknowledge Heather Noga from the Endometriosis and Pelvic Pain Lab for helping with the data collection for this study, and all my teammates at the video lab. Thank you.
Thank you very much. So next up, we have Maggie Kinchella. Maggie Wu Kinchella is a PhD candidate in the Women and Children's Health Sciences program at UBC. Maggie holds a Vanier Canada Graduate Scholarship, a UBC four-year doctoral scholarship, a Friedman Award for Scholars in Health, UBC Public Scholars Award, and was one of the emerging voices for global health in 2020.
Okay, thank you so much for having me here. So Dr. Rideout, in the opening, talked about the value of collaboration, which is really at the core of the work that I will be presenting to you today, about knowledge mobilization efforts to strengthen maternal nutrition in Kenya. So my PhD work was embedded in the PRECISE network, Prospective Pregnancy Cohort, in Kenya, Mozambique, and the Gambia, which brought in some representation from Eastern, Southern, and Western Africa. Gambia is quite a small country, so I put an arrow there to highlight it. And it involved dietary diversity assessments within the PRECISE cohort, as well as 3 months of field work with community members to really understand their perspectives and experiences with maternal diets. For what I'm presenting on here today, the knowledge translation work was really focused in Kilifi County in Kenya, which I presented with a star there in Eastern Africa in Kenya, where there was heightened interest due to substantial food insecurity due to an ongoing drought. So there was keen interest from Department of Health partners there. And very briefly, I'll welcome any questions on it more later. We found that there was low dietary diversity in the population of pregnant women in Kilifi County. There was a median of 4 healthy food groups consumed in the previous 24 hours out of 10 in the minimum dietary diversity for women tool. And this is below minimum dietary diversity by the criteria. So this would mean that over a majority of women were not did not have micronutrient adequacy during their pregnancies. And from the qualitative findings, what we found was that pregnancy was not always seen as a special period where women needed additional nutrients or needed special meals. And there were special foods only around delivery to help with childbirth or to help with the initiation of breast milk production. And this can really be seen in this quote here of a community leader from Kenya who said, "I have never seen any special meal for a pregnant woman. But when a woman has delivered, you'll see that they're made some soup. The soup is made of legs or tail of a cow, which is boiled and given to the mother. During breastfeeding, that happens during the first few days. She would drink the soup like a week or 2. Afterwards, she would eat whatever foods were eaten by everybody." So with some of these findings, I had the remarkable opportunity through the Public Scholars Initiative, as well as the keen interest of our partners in Kenya, especially the nutrition officer in one of the sub-counties who is very passionate about this. And together with the PRECISE team there, we were able to hold a nutrition stakeholder meeting last July. And some key components of the workshop was that we really tried to emphasize local leadership. And this was to really help promote local ownership. And we did this through the chairing by the nutrition and community health officials there. And then we also really targeted sub-county engagement. So not broadly Kenya, not even broadly Kilifi County, but the specific sub-counties that we were working with to highlight the regional context and the application. And we convened 18 sub-county officials with various portfolios in nutrition, reproductive health, and community health. And then this was a unique part of the dissemination, was I really tried to emphasize, provide a space to discuss knowledge translation. And some of the partners that we worked with kept on asking me, what are your recommendations? What are your recommendations? And I was like, I'm here to kind of talk to you about some of the findings. And I really want to hear what you think moving forward would be the best ways to implement this and actually give that space. And while everyone was gathered together, I think was really valuable. And we also used Slido as well to rank them. So we were able to do that. So my part really ended with the workshop, but conversations continued. And this is almost a dream output of that workshop, was that local officials took ownership of these findings. And very recently, they've implemented a pilot intervention in these communities to promote maternal nutrition through maternity open days, which is an existing program that's delivered by the Department of Health in the region. And that was really what I wanted, was that it would be embedded to improve sustainability. So it leverages these existing programs as well as their networks of community health promoters. And very briefly, there's 2 stages to this intervention. The first, they engage the community health promoters, which is their interaction with the communities, to raise awareness about some of these issues, but also to engage them to mobilize the pregnant women in their communities to these 2 maternity open days in 2 local hospitals, which included nutritional counseling, as well as maternity facility tours, so they could familiarize themselves with the services and the healthcare providers and connect them to a free maternity program. And I'll end there. Big thanks to my supervisor, Dr. Rajawal Alango, as well as all of our collaborators, and Asante Sana to our collaborators in Kenya. Thank you.
So next up, we have Arthi Swaminathan. Arthi is a master's student under the supervision of Dr. Rahavel Alango, affiliated with the BC Children's Hospital Research Institute. She's passionate about addressing the gap in sex data and is currently studying dietary amino acid requirements in women.
Thanks, Amy. Hi, everyone. I'm Arthi, and I'm doing my master's in experimental medicine, and I'm going to be presenting my master's project entitled Leucine Requirements During Different Phases of the Menstrual Cycle in Eumenoid Women. So a bit of background, nutritional requirement studies in women are quite limited. And one of the challenges with studying women is the complexity of the menstrual cycle. And so up until now, we've been using kind of a one size fits all approach to nutritional requirements with women. The idea really that nutritional recommendations that have been studied in men can be universally applied to women. But like hormonal fluctuations during the menstrual cycle really offers a good explanation to not only sex differences, but also differences and metabolic differences between the phases of the menstrual cycle. And so why are amino acids important? Well, we consume protein for amino acids. They're involved in forming tissues, replacing old tissue, and we need to consume essential amino acids through our food. And so Liebig's law of the minimum states that growth is restricted to the most limited nutrient, or in this case, essential amino acid. And so when one essential amino acid is limited or intake of that essential amino acid is low, then body protein synthesis is limited. And leucine is one of 9 essential amino acids, which is the focus of my research, which is involved in protein synthesis, muscle preservation, and also overall metabolic health. And interestingly, recently, leucine has received a lot of attention for its potential ability in enhancing performance and aiding in exercise-induced recovery. And so what is the problem? Well, one, current amino acid intake recommendations for women are derived through studies in men. And two, those endogenous hormonal fluctuations, estrogen and progesterone, well, they influence metabolism and they do affect nutritional requirement in women. And current evidence suggests that amino acid intake recommendations currently may have been underestimated. And so my question is to determine how does leucine requirement fluctuate during the menstrual cycle, and how does it compare to the current recommendations that have been outlined for women? And so my primary objective is to determine leucine requirements in women using the stable isotope based indicator amino acid oxidation method. And the secondary objective is to compare leucine requirements between the menstrual cycle phases, but also to current recommendations. And so the methodology really can be broken down into 3 phases. Phase 1, recruitment of participants between the ages of 20 and 35. And then data collection, which we will be using the indicator amino acid oxidation method. We will screen participants through a preliminary assessment to determine eligibility. And then participants will be randomly assigned to one of 7 intakes of leucine. And then the breadth of our data collection is really the 8-hour study days, where we'll be giving the participant an experimental diet, taking breath samples, urine samples, and blood samples. And then brings me to phase 3 of my research, data analysis, which includes sample analysis and also statistical analysis. And so expected results, well, to date, there's only been one other study looking at essential amino acid requirements in women and comparing it between the 2 phases of the menstrual cycle. And as you can see from the graph there was a considerable difference between the luteal and follicular phase. About a 9 milligram per kilogram per day difference in the phases. And so at all lysine intake levels, they saw that plasma amino acids were lower, phenylalanine oxidation was lower, and also there was a higher lysine requirement in the luteal phase relative to the follicular phase. And future directions for this research, well, this research will improve dietary leucine guidelines for women, but also as we see dietary trends change and shift towards an increase in vegan and vegetarian diets among the population, it becomes increasingly important to determine individual amino acid requirements specific to sex. But also, like I mentioned before, implications of this research extend to athletes and fitness enthusiasts, because leucine does have the potential ability to enhance performance, improve recovery, and also prevent metabolic disturbances for athletes. And that brings me to my acknowledgement. Thank you.
So our next speaker is Erica Wan, who is joining us virtually. So Erica, I'll just ask you to share your screen now.
Okay. Can you hear me?
Yes, we can. So Erica is an undergraduate student at UBC studying microbiology and immunology. She's also a research assistant in Dr. Badawi's recurrent pregnancy loss lab, and she's especially interested in women's health and medicine. So you can take us away, Erica.
Thank you for the introduction, Amy. My name's Erica, and today I'll be discussing the impact of the COVID-19 pandemic on births, following spontaneous conception and in vitro fertilization in British Columbia. So just a quick recap on COVID-19 in BC. We had our first reported case back in March 5th, 2020. The World Health Organization declared the outbreak of SARS-CoV-2 as a global pandemic on March 11th, and the Canadian Fertility and Andrology Society recommended the suspension of non-urgent reproductive care on March 18th, and this includes IVF cycles. And this was reflected in other reproductive medicine societies as well. So while the impact of the COVID-19 pandemic on pregnancy has been studied, its impact on conception rates and reproductive outcomes in pregnancies achieved through both spontaneous conception and IVF are not as well understood. So we had two primary aims of the study. One was to understand the effects of the pandemic on monthly conception rates in BC, as well as to compare the differences in maternal characteristics and pregnancy complications before and during the pandemic. So this is a retrospective population-based cohort study, which included all live births and stillbirths conceived from January 1st, 2010 to June 30th, 2020, recorded in the BC PDR. Conceptions that did not result in births, so pregnancy losses, miscarriages, and conceptions with missing information were excluded from the study, and participants were between 15 and 49 years of age. So overall, we had 466,104 births that were conceived during the study period. Pre-pandemic, about 3.7% were IVF conceived, and during the first 4 months of the pandemic in our study period, 2.6% were IVF conceived. We then looked at maternal characteristics in those who conceived prior to and during the first 4 months of the pandemic, and we found that there was a higher average maternal age, as well as pre-pregnancy BMI during the pandemic. There's also a 2% increase in self-reported drug use in pregnancies conceived during the pandemic, as well as a higher prevalence of mental illness history. We also found that there were higher prevalences of preterm birth, gestational hypertension, and gestational diabetes in those who conceived during those first 4 months of the pandemic. But we found no changes in ICU admission rates or multiple gestations. So this is a graph showing our total conception rates. In black is our observed rate, and in the red and blue, we have our expected rate based on ARIMA models, forecasting what we would expect to see for conception rates given previous year's data. And as you can see, pre-pandemic, there was quite a bit of overlap between the observed and expected, which means our ARIMA model was working fine. And in March to May of 2020, we also found some overlap in those conception rates as well. But in June 2020, we found a drastic divergence in the observed and expected rate. So we saw significantly less conceptions than we would have expected given previous year's data. We also looked specifically at IVF conception rates. Again, pre-pandemic, there was quite a bit of overlap between the observed and expected rates. But then in March 2020, there was another dramatic divergence. So a lot less observed rate than we would have expected. And it slowly seemed to increase back in May to reach near forecasted levels by June 2020. So based on other studies that have been done, it seems that COVID-19 impacted people's decisions to conceive. Seems like many people abandoned or postponed decisions to conceive due to economic worries or worries about how the infection would affect mom and the baby. And our data suggests that there could have been a similar decision to delay or avoid conception in BC, particularly around that June 2020 mark. The CFAS issued guidelines on safe resumption of care on April 29th, 2020. And then shortly after that, within the first few weeks, fertility clinics across Canada resumed services. And these policy changes are reflected in our findings. So in March 2020, we found a dramatic decrease in conception rates by IVF, followed by an increase in May 2020 to near forecasted levels in June. So the main takeaways of the study is that the rates of preterm birth, gestational hypertension, and gestational diabetes increased in pregnancies conceived between March to June 2020. There was a great decrease in overall conception rates observed in June 2020, potentially indicative of people's decisions to delay conception. And suspension of diagnostic and elective procedures delayed IVF cycles and subsequently affected IVF conception rates in BC. Just would like to acknowledge Dr. Mohammed Badawi, who's my supervisor, as well as the Badawi team. And that is the end of my presentation. Thank you so much for listening.
Thank you, Erica, and thank you to all of our wonderful speakers. I'll just ask our in-person speakers to join us in the front now for a little Q&A session. And I want to remind everyone in the room that if you have a question, you can feel free to raise your hand. There are actually buttons in front of your chairs. If when you're asking your question, if you could press that button at the same time, that way everyone online can hear you as well. That would be great. And for everyone joining us virtually, I just want to remind you that we have our Slido code, which I will share with you all again. So it's just hashtag TRP. And then similar to the first session, if you'd like, you can also unmute yourself to ask your question. So with that, I'll ask if anyone has any questions. Oh, okay, all at once. Maybe we'll start in the back and move our way down.
I was wondering for the amino acid study, how did you go about timing the follicular and ovulation phases?
Yeah. So for the follicular phase, we're looking at days 3 to 7 after the onset of the period. And then for the luteal phase, we're looking at day 4 to 7 before the onset of the next cycle. But we're using a fertility monitor that looks at the LH concentration in urine to kind of track when ovulation happens and then count down from there for the luteal phase.
Catherine?
Maggie, your project sounded really fascinating and also fulfilling. A little bit jealous, to be honest. But what I'm curious about is what were some of the challenges that you encountered as you were working with the community, and how did you overcome them?
Challenges for me personally doing research in the community, or challenges that I found in the research?
I think, yeah, just working with the community, like you obviously have a really good understanding about how meeting individuals with where they're at and making sure that they feel empowered is, a key to success. I'm wondering, in that sort of relationship building and throughout the process of conducting research, what were some of the challenges that you faced?
One of the challenges for sure is language. I do actually speak a little bit of Swahili, but it's very rusty. But I think in some ways, me trying probably helped a lot. But a lot of it was that I worked through partners, and that was really the collaboration, is that I really tried to come with a bit more of a flexible research objective, a bit more broad, to really understand what people wanted to work with. And I think a lot of it, some of the challenges included accessing some of these communities, language, some of the things that are maybe a little bit more taboo to talk about, they might not want to talk about right away. So a lot of it was working with partners and working with and through partners. And then for my qualitative methodologies, I used the focused ethnographic approach, where I triangulated 3 different types of qualitative methodologies, including in-depth interviews, participant observation, and photo voice. And through that, I was able to gain more rapport and gain more understanding of the communities and their perspectives.
Great, thank you.
Thank you.
Dr. Huntsman?
This is a question for your endometriosis research. When you were looking at the different hormonal therapies, was there a decision tree approach? If someone took cyclical CHC, and then would they not appear elsewhere on the list, or could somebody appear more than once on your list if they went from one treatment to the next?
Multiple treatments, like some patients used more than one treatment, and every time the patient used different treatment, it's count once, in each category.
Okay, so the same individual could
more than one time. Yeah.
Thanks very much.
So we do actually have a few questions on Slido as well. I'll get right back to you. So The first question is related to the conception study. For substance use, age, and BMI, are these differences just differences over 10 years, or would you say it's a pandemic effect? And I think that's directed to Erica.
We use descriptive statistics for the figures that I had in my slides. So it could be over time, not just due to the pandemic, but we do actually have ARIMA models that were made. And we did find there was a slight increase, especially in mental health, mental illness history, and then drug use.
Okay, thank you. And then there's another question for you. Was there a rebound impact of IVF rates for people who delayed their pregnancy?
Rebound as in like, because they weren't, sorry, I could just hear a little bit of feedback, but like, because there weren't like accessibility during the pandemic afterwards, there was like an increased amount. Is that what the question is referring to?
I would assume so, but if the person who asked the question would like to unmute themselves and clarify. But yes, I would assume so.
I assume so. Oh. I assume so. Sorry, I don't know if someone's speaking, but I assume there was. We weren't really able to find that though because our study ended June of 2020. So if there was a rebound and maybe we saw that those numbers kind of slid down the further we went along, that would have been more indicative, but unfortunately we were limited by our study period.
Thank you. I think we had a few more in-person questions. Yes, you can go ahead.
So I was just wondering, like the first question when I heard about the knowledge translation project was why Kenya?
Okay, so the question was why Kenya for knowledge translation? Thank you so much for that question. A part of it was because there was keen interest from the Department of Health officials there. And a part of it was they actually reached out to me, which was really exciting for any trainee. And working with them to kind of develop some of these, this knowledge translation piece. And the second was that in coastal Kenya, there was a lot of concern about maternal and child malnutrition because they had been experiencing a multi-year ongoing drought that has devastated their agriculture. At the time of research, which was around 2022, April 2022, they were also just coming out of COVID policies, which had a lot of impact in their economy. And then there was also global politics where there was a lot of inflation in food prices. So this was recognized as a key issue. But I think one of the themes of this women's health research cluster, as well as these presentations, is that there's not always a focus on women's health. There was a lot of discussion around child malnutrition or child health outcomes, but there was not very much research about what about the women and how was this an issue in their communities. So that kind of was one of the reasons why we focused on Kenya.
Well, personally, really understood. And it sounds like there are so many like layers to the problem. Like, you know, there's like policy layer, there's like community layer, there's like personal, like social cultural level layer to it. So like, I was wondering like, so one of the interventions, like pilot interventions that was done was within the community where they were trying to do like the maternity open day stuff. But I was wondering like, were there any conversations about any other types of layers that we're trying to like address? Yeah,
that's a great question, and I wasn't really able to get into that in the presentation, but we had a number of ideas that were proposed, including engaging men in talking more about pregnancy nutrition, not just for the baby, but also for the mom, which meant a focus on pregnancy nutrition throughout gestation, not just at the end. And so there was talking about how can we engage men who are decision makers in their households. Other ones were talking about a small grant, business grants for women, so they can further strengthen some of their business ideas, to think about some of those underlying determinants of health. But in the end, because of, I think, maybe just feasibility, they went with the more knowledge building and raising awareness approaches. Thank you.
Okay, I'll just quickly check if there are any more questions.
I was a little, sorry, is there another one?
No, go ahead, David.
The amino acids, how did you go from all amino acids to leucine? And so are the, and probably if you had a 20-minute talk, you would have included that, but so are your findings, would they indicate that there are other amino acids which were either different or similar varying needs?
Yeah, well, the goal is to get through all of the essential amino acids. Like I said in my talk, lysine has already been looked at, and that's the only study that has looked at the phase differences in women. Leucine was just kind of a natural next step for me in terms of its implications with exercise and in athletes. It was just a personal interest of mine.
Okay, thanks.
And I think there was one more question.
We have time. For the endometriosis study, I was curious if you had any insight on the association with anxiety and depression, in the sense of whether that's sort of pointing to central sensitization, or if that's at a quality of life, kind of like the chronic pelvic pain comes first, then the anxiety and depression, or the other way around. Do you have any sense of that?
From the variables we studied components of central sensitization, some clinical components, pelvic fibromyalgia, IBS, interstitial cystitis, and we found association between central sensitization and ineffectiveness for mortal. And we also looked at quality of life. We used HB30 scores, questionnaires. And again, we found correlation between hormonal therapy effectiveness and poorer quality of life. Regarding the point time, this is like a kind of cross-sectional study, like patients were asked during their first appointment, like where they are filling out the questionnaire. So you can't like be sure that which came first. So our plans, like we are following patients, like we are sending questionnaires every year for 5 years since their initial visit. So we are planning to run something longitudinal to see which come first and which affect which.
And with that, I will invite up Catherine Moore for some closing remarks.
Oh, wow. That was so amazing. I can't believe how much research we covered today. Thanks, Amy, and thanks to all of the speakers. And honestly, from the bottom of my heart, I just want to say thank you to all of you for choosing to focus on women's health in your career. Given that women were excluded from clinical trials in Canada until the early 1990s, the work that you're doing is filling a critical gap in knowledge that's going to positively impact everybody around the world. So let's just have a final round of applause for all of the speakers and yourself. Why not? And for the trainees that are here today, I just want to let you know that these 3 organizations, we really, really care about you. We want you to feel welcome in our space, and we really want to help you become the best professional that you can. So take a minute, have a look at this screen. These are the different initiatives that we have going on all of the time, but just over the next couple of months, this is what we have coming up. So in the Women's Health Research Cluster, we publish bi-monthly blogs. We have a monthly podcast. We have a monthly seminar series, and it all features multidisciplinary research on women's health. So it's not specifically focused at clinical, which is probably what you guys are all interested in. But if you're looking to expand your knowledge about women's health, these are some opportunities for you. And in addition to that, just like Dr. Huntsman said at the beginning of the session today, the Gynecological Cancer Initiative has an amazing annual trainee conference, and it's focused again specifically on you and helping you. So if you're looking for opportunities to cultivate your public speaking skills or to network, definitely get a ticket to that event. And the WHRI has a lot of these initiatives as well. They have fantastic events to go to. And in the next month, they have coming up their Research Wellness Exchange and the BC Women's Research Rounds. And if you haven't checked out their podcast, you really, really should. They have episodes coming out all of the time as well. So please do get in touch with us. We want to help you. Just let us know how we can. So for those of you who are in person today, we have a network session coming up for you. Networking is a fantastic opportunity for you to build your professional network, learn about different insights in your field, and also, just learn from each other and to share what you have to offer others as well. So after we conclude today's session, we've got some snacks in the back of the room. Please do pocket some. You're more than welcome to take more than one. And I encourage you, break out of your group that you came with and introduce yourself to at least 2 new people. If you find that scary or intimidating, you're not alone. So I'm going to leave up these question prompts for you. But, just to give you an example, it's pretty easy to just say, hey, my name's Catherine. Like, what are you working on? What do you love the most about your job? Or what is some advice that you have received in the past that you found really helpful? People love helping others, so give them an opportunity to, and you may make a really great collaborator or a good friend. So, so we encourage you to do that. All right. In closing, I just want to say a huge thank you to all of the people who made this event possible. I want to say thanks to Amy and Alex for moderating the session and coordinating the event, to Emily, Madison, Elmira, and Michelle, the Gynecological Cancer Initiative, to Nicole, who's been our tech guru, and KT extraordinaire, Olivia, and Rebecca, who helped me find this room in this very confusing facility. So thank you, everybody, for coming. We really loved having you, and we can't wait to have the next one. Have a wonderful day, everyone.